female genital mutilation/cutting, FGMC, refers to all procedures that involve partial or total removal of the external female genitalia or other injury to the female genital organs for non-medical reasons. Today, at least 200 million girls and women alive have undergone FGMC, and every year over 4 million girls are at risk of undergoing this procedure. In 2015, the international community agreed to end FGMC by 2030, including the eradication of FGMC in the UN Sustainable Development Goals. Various policies and interventions implemented to counteract the practice of FGMC has resulted in declining FGMC prevalence rates in many countries. However, ending the practice by 2030 remains challenging. According to the World Health Organization, the medicalization of FGMC is one of the major challenges within the fight towards FGMC abandonment. Medicalized FGMC is defined by the World Health Organization as a situation in which FGMC is practiced by a healthcare provider, whether in a public or private clinic, at home or elsewhere at any point in a female's life, thus referring to the practice being performed by a trained health professional. The most recent guidelines issued by the World Health Organization on the management of health complications from FGMC states that stopping medicalization of FGMC is an essential component of a holistic, human rights-based approach toward the elimination of the practice. A human rights-based approach puts the rights of women and girls at center stage and aims to safeguard the rights of girls and women to bodily integrity and sexual health and well-being. The human rights-based approach frames all forms of FGMC as a violation of human rights. From a health-centered approach, FGMC is framed as a health issue, and medicalization might be seen as a safer way of performing FGMC. The discussion here is whether medicalization should be implemented as a harm reduction strategy, particularly in communities where the reduction of abandonment of FGMC is not yet feasible, as the health risks are being perceived as less harmful than the adverse social and cultural consequences that girls and families experience when they leave their daughters uncut. In our paper, which is still under review and thus work in process, me and my colleagues Hazel Barrett, Samuel Kimani, Irwan Hidayana, and Els Rijen, we argue that from both perspectives, the human rights-based approach framing all forms of FGMC as a violation of human rights, and the health-centered approach framing medicalized FGMC as a health issue, that the current definition of medicalized FGMC should be critically revised. For the health-centered approach, the current definition of medicalized FGMC is inadequate in documenting a decline in the risk of adverse health consequences, as the definition only focuses on the professional status of the FGMC practitioner. From the human rights perspectives, we can question the relevance and utility of defining and targeting medicalized FGMC as a separate practice, and argue that medicalized FGMC should be rather framed within a broader, expanded variety within the practice. We believe that rethinking the definition of medicalized FGMC could deliver a useful framework and vocabulary to discuss FGMC in its real-life diversity, whilst concurrently clearly identifying it as a form of human rights violation. Discussing various case studies and scenarios on the ground, we aim to demonstrate that it's important to take into account more than the who performed the practice when discussing medicalized female genital mutilation/cutting. We show that it's also important to look at other components, more specifically the what, referring to the type of FGMC performed, the where, referring to the location where the procedure is performed, and the how, referring to the material used when conducting the practice. Before going further, I would like to emphasize again that what I'm presenting here today is work in progress, that we are still reflecting about our work, so feedback and suggestions are very welcome after this presentation. So, concerning the who of medicalized FGMC. The current definition of medicalized FGMC is primarily on who performs the practice. Here, the first issue on the ground is pseudo-medicalization, as anyone who works in a health facility, even if they lack clinical knowledge or did not receive any formal medical training, may be construed to be a health worker and thus may perform medicalized FGMC, especially in countries where health systems are overburdened and experience shortages of healthcare professionals. Such pseudo-medicalization may occur. In this line, for example, a study conducted in Guinea shows that most respondents did actually not know the position nor education of healthcare professionals performing FGMC. A second issue related to the WHO on the ground here is that whilst health professionals are often perceived as specialists in performing safe FGMC, surgical skills and clinical knowledge with regard to performing FGMC, prevention of FGMC, and providing care for women and girls who have undergone FGMC varies a lot within a health professional. In this line, it shows that there's a research that shows that health professionals themselves acknowledge that they did not have the required knowledge and skills to provide even good quality care to women and girls who have FGMC. Moreover, thirdly, in countries where the prevalence of medicalized FGMC is high, the role of different healthcare professionals varies. For example, in Egypt, FGMC is often performed by doctors, whilst, for example, in Indonesia, it is reported that midwives were the main providers of FGMC. Going to the next box, the how, referring to the material used during cuts, and the where, the location where FGMC is performed. The assumption often is that traditional cutters use traditional instruments, such as a traditional cutter's knife or thorns, whilst health professionals are assumed to use medicalized surgical instruments like anesthetics and antiseptics. And moreover, medicalized FGMC performed by health professionals is often associated with the practice being undertaken in sterile environments, such as hospitals or doctor offices, which is referred to as clinicalization. However, in reality, the difference between practitioners performing FGC and the materials they use and the location where they perform it is not so straightforward. On the one hand, health professionals do not always use sterile equipment when conducting FGMC, nor do they always perform FGMC in a sterile environment. For example, when I was doing research in Eekert, Kenya, I learned that healthcare professional performed hidden medicalized FGMC at girls' home, or sometimes as well in private clinics, to avoid prosecution. On the other hand, in several countries, for example, Sudan and Somalia, it is shown that medical instruments and anesthetics are as well often used by traditional practitioners to carry out FGMC. Going to the third box concerning the what, the type of FGMC, medicalized FGMC is often assumed to be associated with less severe types of FGMC and therefore to reduce physical health risk compared to FGMC performed by traditional cutters. However, looking at various case studies, we observe that the type and severity of FGMC performed by healthcare professionals varies over time across regions and communities. For example, while in the Abagusi community in Kenya, health professional prick or nick the clitoris, amongst midwives in Indonesia and doctors in Malaysia, research shows that more severe types of FGMC are performed. But then comes the question, what do we actually learn from this? We have summarized scenarios on the ground. The various case studies and scenarios of FGMC with different medical interventions show a broad range of FGMC practices, going from traditional FGMC, which you see here in type in, with no medical interventions, to clinicalization of FGMC, where the practice is performed by a trained health professional within a health facility using medical instruments. Here's shown as scenario 4. But what do we learn from this? Why do we think it's important to show these scenarios that happen on the ground? We believe that rethinking the definition of medicalized FGMC by representing the variety of the practices and realities on the ground is important in the fight towards FGMC abandonment for several reasons. First, It will enable more reliable data collection on FGMC and allow trends within the practice to be identified and comparisons to be made. Second, it will assist in developing more targeted policies and programs to prevent FGMC adapted to the specific forms of FGMC. Thirdly, rethinking medicalized FGMC based on the discussed scenarios could deliver a useful framework and vocabulary to discuss FGMC in its real-life diversity on the ground, while concurrently clearly identifying it as a form of human rights violation. This vocabulary can be introduced in training healthcare professionals and consequently would contribute in strengthening health systems to improve FGMC prevention and care services. Moreover, using these scenarios to inform such framework recognizes the health professionals' dilemma of reducing health risk of supporting the full abandonment based on human rights, and intends to provide more accurate vocabulary and data to discuss and tackle this issue. Thank you.